Hello, everybody. Thank you so much for being here. We're just going to give folks a couple seconds to funnel in. And then we will get started. Amazing. And I see we have 31 people already who have joined us. It's nice to see you all here. Make sure my flipping goes back and forth. Perfect. All right. Well, for time purposes, I am going to get us started. Hello, everyone, and thank you so much for joining us for today's panel discussion on diagnosis of Tourette syndrome in adulthood. My name is Alexandra Walsh, and I am the manager of programs at the Tourette Association of America, and I will also be your moderator tonight. Participants will have the ability to engage in a Q&A discussion with our panelists at the end of the presentation, so please feel free to place your questions in the Q&A box throughout the presentation. We also ask that you please take the time to fill out a brief survey at the end of this presentation using the QR code that will be provided for you on the screen. Your responses provide us feedback on our programming and the ability to host more programming like it in the future. Tonight's presenters will be Dr. David Isaacs. Dr. Isaacs is a movement disorders neurologist and co-director of the Vanderbilt Center for Tourette Syndrome and Other Tic Disorders, a TAA Center of Excellence. He provides clinical care to children, adolescents, and adults with TS or other tic disorders. His research examines the clinical impact and neurophysiologic correlations of non-motor features of Tourette syndrome. Next, we have Dr. Charles Galen. Dr. Galen is a licensed psychologist and co-owner of the Knoxville Behavioral and Mental Health Services. He serves as co-chair of the OCD Training Committee for the Association of Contextual Behavioral Sciences and is an active member of a statewide professional group out of Vanderbilt University Medical School for the Center of Excellence for Tourette Syndrome. Last but not least, we have Darren Bush. Darren has worked with the TS community in various roles for 30 years. He has tutored, lectured, taught classes, run workshops, led panels, and facilitated support groups. He has worked with the Tourette associations in both the US and Canada. Darren has also written short stories and jokes, invented words, designed t-shirts, created theories, and blogged about TS and its co-occurring conditions. He has several neurological disorders himself, including TS, ADHD, and OCD. He also has sensory handwriting and reading difficulties, as well as a learning disability that he loves to discuss. Without further ado, I'm going to pass it off to Dr. Isaacs to get us started for tonight's presentation. Take it away, Dr. Isaacs.
Okay, thank you, Alexandra. Thanks to the TAA for allowing us to present, and I'm very excited to share the virtual stage with Charles and Darren. And so we have a lot of information we wanted to cover tonight, and we're going to spend about the first 45 minutes, each of us kind of talk with about 15, 20 minutes or so, talking about specific topics that were brought up in the pre-registration, and then we'll have some time at the end for Q&A. And so we're looking forward to your questions. So we'll go ahead and get started. So Alexander, if you don't mind, move into the next slide there. I'm going to start my watch to keep my time. Okay. So I'm really going to focus on how we diagnose Tourette syndrome. And to do that, I'm going to talk about what the criteria are and then walk through and give a little bit of explanation about why those criteria were selected. How did we actually arrive at these and why do we use these as opposed to different, other criteria? So on the slide here, you'll see it says it has Tourette syndrome and has 4 bullet points. And those are the clinical, we call diagnostic criteria for diagnosing someone with Tourette syndrome. These criteria are in what's called the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders. This is basically it's a manual for how to arrive at clinical diagnosis of different neurologic and psychiatric diagnoses. And there have been different iterations, different versions over time. As we understand more about these different disorders and disease processes, this manual gets revised. And so as soon as they publish one, they're already sort of starting to work on the next version. So the initial one was just the DSM. And then obviously now we're on the 5th version of this. So for Tourette syndrome in the DSM-5, these are the 4 criteria: the presence of 2 or more motor tics and at least 1 vocal tic. Tics have to be present for at least a year. They have to have started in childhood or under age 18. And there cannot be a better explanation for the tics. And so if someone satisfies those 4 criteria, then we would diagnose them. I would diagnose them with Tourette syndrome. So there is no, we call biomarker. There's not an MRI or a brain scan or a blood test that we use to make the diagnosis. It's based purely on a clinical interview and an examination. You'll see in the box below a persistent, or it's also called chronic motor or vocal tic disorder. That's a separate diagnosis, but we really do think about persistent motor or vocal tic disorder and Tourette syndrome as part of a family, really as part of we think that the underlying biology of those disorders is shared, is very similar or even the same. And clinically, we treat them the same. The only difference between those and Tourette syndrome is if someone only has motor tics, so they never had a vocal tic, they would not meet the criteria for Tourette syndrome. You have to have a vocal tic. So we would diagnose them with a persistent motor tic disorder as long as they met the other criteria, that they had tics for at least a year, tics started in childhood, and there was not a better explanation. And the same is true if you only had vocal tics. So while we do separate those, they are separate diagnoses. We do think about them as part of like a family, a spectrum of tic disorders. And collectively, we often call these persistent or chronic tic disorders, which encompass Tourette syndrome, chronic motor tic disorder, and chronic vocal tic disorder. So Alexander, will you advance to the next slide, please? And so I'm going to talk a little bit about each of these bullet points, each of these criteria, and I'm going to talk about Tourette syndrome, but what I'm going to say applies to chronic motor and vocal tic disorder as well. And so in the upper right of the slide, you'll see those 4 criteria listed again for Tourette syndrome. And I'm just going to, like I said, give a little bit of context for each of those. So the first is we're talking about Tourette syndrome and other tic disorders. Obviously, they are defined by the presence of tics. And so it's natural. What is a tic? And that's actually a trickier question than one might think to answer. It's something that we're constantly trying to get better and more precise in our language of how we define it. But there are some general characteristics that help in understanding what a tic is. First is that we say stereotyped, meaning when it happens, it's the same each time, or it's very similar. So if someone has a movement that looks the same each time, we would call that a stereotyped movement. Or if there's a particular sound they make that is the same each time, we would say it's a stereotyped sound. So tics are stereotyped. In contrast to some other kinds of movements, tics are suppressible generally. Again, there's some exceptions to this. Some people would argue, understandably so, that it's hard to suppress their tics or they can't suppress their tics. So that's why it says often suppressible. But by that, we mean if someone really thinks about it or concentrates, people can often, at least temporarily, keep their tics at bay or hold them in. Now, that can be uncomfortable and it can be difficult. And like I said, for some people, it may not be possible. But we generally think of tics as suppressible. Some other kinds of movements, things like certain kinds of tremor or other kinds of what we call myoclonus or jerks, are not suppressible. And so that's why that is mentioned in there, is because it does differentiate it from other kinds of movements. And then tics also often, again, not always, you'll see there's lots of exceptions, which is why, again, defining a tic is actually more challenging than one might think. But tics are often preceded by an uncomfortable sensation that we call the premonitory urge. This seems to become more noticeable, or at least it's more commonly reported as people get older. So in adolescents and adults with tic disorders, about 90% or more will endorse some premonitory urges. It's less. The prevalence is lower in younger children. It's not exactly clear why that is, but nonetheless, premonitory urges are a common characteristic that we see with tics. And then we often also talk about, kind of further break down tics as talking about simple tics, which are quick, very brief movements, typically involving a single muscle group. This might be like an eye blink or a head movement, or a simple, like a sound, like a throat clear, for example. Those we would call simple tics, versus complex tics, which would often be a little bit longer in duration. They might involve multiple muscle groups, or to someone who's observing an individual with tics, they might appear purposeful. Now, this is not a black and white, a binary where that's clearly simple and that's clearly complex. It's often very gray about whether a tic is simple or complex. So these are really useful guides more than hard and fast, in concrete truths about how we kind of frame and describe tics. Next slide, please. And so the reason why it's difficult, besides, as I was talking there, you saw, I mentioned that often, or used generally, lots of kind of qualifiers talking about how we define a tic. So even defining it is challenging in and of itself. And it's also difficult to differentiate sometimes tics from other kinds of movements that share a lot of those same features. So these are just a couple, and I'm not going to go, because of time purposes, go into great detail of these, but these are other kinds of movements or behaviors that can sometimes be mistaken for tics. So one is what's called a stereotypy. In the kind of the non-medical parlance, this would be something like people might have heard stimming, like in individuals with autism. It can also happen as part of normal development. People can have repetitive movements that they do, things like hand flapping or rocking, that are stereotyped, hence the name, stereotypies. But they do have some differences from tics. There are many people actually who have stereotypies will find them soothing, or at least neutral. They're not typically bothered by them. Maybe they can be socially distressing, but they don't feel often like a discomfort from them, like someone often might describe with a tic. But there's definitely can be a blurry line separating a stereotypy from a tic, and people can have both kinds of movements. Compulsions are another common behavior we see in people with tic disorders that's very hard sometimes to separate from a complex tic. And so compulsions are repetitive behaviors, things like hand washing. They're often done in response to different kinds of intrusive or unwanted thoughts. The sense that my hands are dirty, even though I haven't been doing anything that would make them dirty, and therefore I need to wash them. The compulsion is kind of a follow-up or associated with that intrusive thought. So, but to an outsider, to someone kind of watching an individual, what a complex tic is versus a compulsion can be really hard. And even for people who work with people with tics or have tics themselves, it can be very hard to separate, well, is this a compulsion or is this a tic? So my point in mentioning these different kinds of movements is just to say it really can be challenging sometimes to be definitive. That's what this is. But there are some other helpful features that give us some more clarity. And so if you'll advance, Alexander, to the next slide. And so one of these is what I've been talking about is kind of, if I was talking to an individual for example, in a clinic room and kind of talking about what they were feeling, what they were experiencing right now. But obviously these symptoms, tics, also happen over the period of time. So we talk about what's called the clinical course, or the course of tics. And that can be really helpful because that's often a little bit different than some of those other movements and behaviors that I was describing on the previous slide. And so that's why in the diagnostic criteria, in addition to the presence of tics, we talk about, well, how long have tics been there? And then when did they start? So the course of the tics really also is helpful in determining, yes, this is a tic, most likely, and two, this would fit in with the pattern of Tourette syndrome. And so why is there this 1 year mark? What's magical about 1 year? And really, there isn't anything magical about having tics for 364 days versus having it for 366 days. But what is important, what's being emphasized with that criterion is that some people do have tics that will come on and then go away. And we call those transient tics. And that's actually much more common than having persistent tics that do last for longer than a year. So around 3% of the population will have tics, transient tic disorder, will have tics come on, and then they'll resolve within a period of 12 months. Whereas Tourette syndrome, based on some various prevalence estimates, is around 1 to 2% of the population. So about half as common as transient tic disorder. And so this is to help us differentiate between those different types of tic disorders, which we think do have some different implications. Now, to throw a bit of a curveball, if you'll hit one more, make one more advance, Alexandra, there is some new data out of the group at specifically at WashU's been doing some interesting work following people who have tics over time, from right when their tics start, or as within a few weeks or month of their tics starting, and basically reassessing them over time. And what they found is that we previously thought that a lot of people had tics and they would just go away and they wouldn't come back. And so someone would go to a pediatrician's office and they would be told that, and then the child or the parents or the guardians, wouldn't worry. But if you follow those people over time, what new evidence is showing is that more than we thought actually do continue to have tics. Now, many of those tics may be mild. They may not bother the individual very much. They may not want to seek medical attention or need treatment for them. But the point is that some of our assumptions that tics, for many people just come and go, are probably incorrect, or at least we were overconfident in how we conveyed that information. And so for more people continue to have tics over time than what we previously thought. Next slide, please. And so when I'm talking about this course of tics and that they last for a year and then that they start under 18, the reason this is important is because we think of, and we consider Tourette syndrome what's called a neurodevelopmental disorder. And all that means is that the symptoms emerge at key or expected time points over the course of development. And there are many neurodevelopmental disorders, and on this slide, you'll see a few listed here. The most commonly recognized ones would be things like ADHD or autism spectrum disorder or anxiety disorder, schizophrenia. And with each of these disorders, and Tourette syndrome included, when the symptoms start and how they change over time does follow a general trend. And we believe that is because of basically the brain's development, what's happening in the brain as you go from birth to reaching adulthood, that there are different stages that your brain and nervous system go through. And during those stages, certain symptoms of certain disorders are more likely to occur. And so that's when we talk about a neurodevelopmental disorder, that's what we're talking about. And that's why a lot of these criteria about the time length and when the tics start are there, because we think about tics and Tourette syndrome as part of this neurodevelopmental spectrum. And this slide is just showing that in these other disorders, what we would often expect, symptoms of autism disorder, we would typically expect some symptoms, earlier in childhood is, around 2 or younger. ADHD, really 3, 4, 5, we start to expect to see some maybe hyperactivity, dribble with attention. So there's general ranges of when we expect these symptoms to occur. In Tourette syndrome, and actually, if you can go to the next slide, Alexandra. In Tourette syndrome, there's a wide range, but this graph gives a general kind of you could say an average, where if you looked at 1,000 people and took the mean, took the average of when their tics started and when their tics peaked, you might get a curve like this. So it doesn't reflect any one person's experience, but it reflects a large group of people's kind of collective experience, which is that most people's tics actually start between the ages of 4 and 8. There are definitely exceptions to this. I've seen people whose tics started, I've seen people in clinic who are younger than 4 who had tics. And similarly, I've seen people whose tics started in adolescence. So again, this is not to say that if your tics start out, don't follow this graph, that it's not Tourette syndrome. That's not what I'm saying. It's just that this is a rough rule of thumb for what we would expect, where tics start between 4 and 8. There's often an increase in the severity of the tics as they approach early adolescence, around 10 to 12. And then as people move through adolescence into their teenage years and late teens and early 20s, the tics often get better. Now, by often get better, I am not saying that tics go away. And actually, and if you'll make one more advance, Alexandra, there is, and sorry, one more again. Thank you. We used to also, again, incorrectly tell people, and I think, unfortunately, this is still told in different clinics and offices, that most people's tics will go away. That it's a childhood disorder, and that as you get older, that the tics will resolve. And as many people in this in this group, on this call tonight webinar, are aware, that's certainly not the case for individual experiences. And even when you look at lots of people, it's really blatantly untrue. So there was a nice paper that was done out of the Johns Hopkins group a couple of years ago that looked at all of the studies that had been done following people who had been assessed in childhood and then reassessed as young adults or older adults. And what they found was that only 10 to 20% of people's tics resolved when they entered adulthood, which means 80 to 90% of people with Tourette syndrome in childhood continue to have tics as adults. So the story really is that most people do have tics as adults, that they may be better and they may not be. They may be better than they were in adolescence. But the point is that the tics do often persist. And we know that for many people, that the persistence of those tics is bothersome, that the tics cause pain, they cause social distress, that, they're unwanted. I mean, maybe it's common sense to say so, but I think it's important. And we know that it has a functional impact. People avoid certain situations. It affects their work. It affects their social life. And so the point is that, a lot of the research and clinical work that's been done has really focused on children, which is obviously, I think everyone would agree, is very important. But I think, as the TA recognizes, everybody in this in the webinar tonight knows, we really do need to spend more time in thinking about and focusing, well, what's the long-term after childhood? What's the lifespan, and what happens as people enter adulthood? Next slide, please. A question that was brought up as part of the, and I'm going to move a little bit quick here because I know I don't want to cut anybody else's time here, is what about tics that could tics start in adulthood? And the answer is it's kind of unclear. Many people who present and say that their tics are, will report that their tics started as adults. In some studies, they've gone back and either in clinical charts or asked family members or looked at videos, and they have been able to identify maybe subtle tics in childhood. And so this is really not an area that's been studied extensively. So everything I'm going to say, I'd say, is quite speculative, but we think that many people may have what's called a recurrence of their tics as adults, but that in fact, there were some tics likely in childhood. Now, is that to say that people couldn't have tics that first started in adulthood? No, I can't say that. What I can say is that, again, thinking about Tourette syndrome as a neurodevelopmental disorder, when someone does have tics that really authentically did start in adulthood, it makes us think, is there something else going on? From a developmental standpoint, having tics start when you're 30 versus when you're 5, the nervous system, the brain, is in a very different developmental stage. And so that makes us think maybe there are other processes at play. And so actually, next slide, Alexandra. And so the very last criterion that's on that list for diagnosing Tourette syndrome is there another better explanation for why the tics are there? And so this is an older paper now from about 20 years ago that looked at what we call, other causes of tics besides Tourette syndrome. And so there are different neurologic disorders, things like what's called Huntington's disease. Sometimes people can have tics as part of that disorder. Strokes have been associated with the development of tics. But the point is that in those situations, the tics may have all those same characteristics where they're stereotyped, they're suppressible, they may have a premonitory urge. But what's different is they don't follow that course over time, where they started in childhood, they peaked kind of in adolescence, that there is this, for some people, an improvement over time, that there's this waxing and waning course. So they have a different longitudinal character, which helps us understand, okay, this actually seems to be a different underlying biological process. And that's why it's important. What we're really trying to do is understand what is the underlying biology driving these symptoms, and could that inform or affect treatment over time? We can advance one more. And so in the last few slides, I'm just going to give a little bit broader context. So I've walked through these criteria for Tourette syndrome and how we diagnose it and why these different criteria exist. Again, they're not perfect, but we're trying to understand what is the underlying biology that gives rise to the different symptoms that people experience. An important point, though, is that these criteria focus on tics, but we know that in fact tics are really just part of the syndrome. That the vast majority, 90% of people with Tourette syndrome, do have co-occurring psychiatric diagnoses. In fact, over half have meet criteria for 2 or more, and the most common being things like ADHD, OCD, mood disorders, anxiety disorders. And so it would be negligent of us to think that Tourette syndrome is just tics. We know, and clinically and from research, from people's experience, that really it is this broader syndrome. And I love the TAA's graphic with the iceberg, because I think it really reflects, or at least what I see clinically, that there's more going on, and how we screen for and treat these other aspects of the syndrome is important for people's quality of life. It's also important for our understanding of the biology of what's happening and what really is this syndrome we're trying to diagnose and treat. Next slide. And actually, I'm going to skip one more time for slide. I'm going to go past this for time purposes. What we also know is that in addition to more common or more prevalent mental health diagnoses in people with Tourette syndrome, is that there are actually higher prevalence of physical health problems. There's higher odds of completing suicide, of substance-related death. There's also higher risk of obesity, type 2 diabetes, and cardiovascular disease. And this may be surprising to a lot of people, but if you actually look at the literature from other diagnoses in the DSM, that Diagnostic Statistical Manual, many of the neurologic and psychiatric diagnoses in that manual are associated with poor physical health. And so we know that this dichotomy, this division between people's physical health and their mental health is very blurry indeed, very porous. And that having a problem in one of those areas seems to predispose, or there seems to be some association with why people might be more likely to have problems in the other. And one more, I think I have 2 more slides, and then I'm going to turn over to Charles. I'm going to 2 other points that were asked about in the pre-registration questions that I'm just going to briefly touch on. One is about this difference in what we say the phenotype, how Tourette syndrome presents in men and women. And there is evidence that there are differences, so which are likely, we say, biologically driven. We think that because of how the brain develops slightly differently in men and women, we think about onset of puberty in girls versus boys, that there are differences also in the course and how tics present and manifest. So, for example, in women, tics seem to start a little bit later, part of which could be due to difficulties with not appropriately diagnosing that in the clinic, which obviously would be a medical, an issue with how we diagnose and address these symptoms when we're in front of a patient. So there also seems to be more likelihood of tics peaking later, meaning the severity of the tics, instead of peaking maybe at 10 to 14, maybe more likely to peak in people's late teens or even 20s. And that there is a slightly lower likelihood of tics remitting, meaning if you're a woman with a girl with Tourette syndrome or tics, that you're more likely to have severe or persistent tics as an adult, as a woman with Tourette syndrome. And there are some other differences too. There seem to be slightly higher rates of OCD in women with Tourette syndrome than men, slightly higher rates of ADHD in men with Tourette syndrome than women. But I will say that we are sort of revamping and looking at a lot of that data, because we also know that, for example, ADHD looks different in women and girls than boys. That women, for example, and girls are more likely to have what we call inattentive subtype of ADHD, which is more likely to be overlooked. It's that the prevalence of ADHD in girls is probably much higher. In fact, it is higher than what we previously thought. And so I think a lot of our thinking about and kind of approaching this, we're starting to take a humble approach, I think, and understanding that really a lot of our prior assumptions and knowledge may be based on some shakier data. And so kind of going back and re-looking at this. And then the very last slide I have, Alexandra, was a question about heritability. I think Charles can talk about this a little bit more in his portion here, which is that we do know that Tourette syndrome and other chronic tic disorders are highly heritable. And that means that if you're an individual who has that your children are more likely to have tic disorder themselves, have Tourette syndrome. We also know that it clusters with other psychiatric diagnoses, specifically OCD and ADHD. there's pretty wide estimates as to what the risk is. So, a lot of times people in clinic will ask me, well, what is the chance of my child having Tourette syndrome? And it's hard to give much more than very broad ranges. You can see here in this middle bullet point that, in some studies that there's a 10 to 100-fold increase in the rate of Tourette syndrome. So that's certainly a substantial increase, but a 10-fold versus a 100-fold difference is pretty substantial. So these are pretty wide estimates. What we do know is that it really does seem to travel in families. But what it looks like in a child and their parent may be very different. And so just because an adult, for example, has more severe Tourette syndrome, that does not necessarily by any means mean that their child will have a severe form of Tourette syndrome. In fact, and I have families that I follow where that's definitely not the case. So I hope that wasn't too quick. I just wanted to make sure I gave time for Charles and Darren, because I know they have a lot of information too. So we can definitely circle back to some of this information in the Q&A here in a little bit, but I'm going to turn it over now to Charles.
Thank you, David. All right, so I'm going to be talking a bit more than about some of the concerns of living as an adult with Tourette syndrome from a clinical perspective. So, like, I'll be talking about some of the things that we tend to see in clinics when working with adults and their families. If you don't mind advancing the slide there, Alexandra. All right, so this is just a very brief overview. There we go. It's a very brief overview of kind of what I'm going to be covering. First, I'll just be talking briefly about the process of recognizing when a diagnosis might need to be made, and a little bit about how we go about doing that, what kinds of things are involved in the diagnostic process, and then talking a little bit about just some of the co-occurring challenges that tend to manifest and the effect that that has on a person's life as an adult, including things like parenting, heritability, like David was talking about, and also the effect on, assuming that there's enough time, so I'll try to talk quickly, but talking a little bit about the effects on spousal relationships as well, because Tourette tends to show up in all kinds of places. So let's go on to the next slide, please. Okay, so signs to look for, right? And I hope you all can appreciate some of the art that I found on Google. I think that it's an amazing resource for enhancing slideshows. So the things that we want to look for, though, that might indicate that an individual may be experiencing effects of Tourette's would be movements or actions that are really, they don't have a clear purpose. There's not a function to them. So it's not something a person chooses to do. And that they tend to have to occur in just the right way, that there is even a right way for these things to be done. And that's different from the normal ways that people tend to engage in actions. Most of the time, people can do things with varying degrees of precision or with slight variations in how they perform an action. But with Tourette's, the tics tend to have to be performed in the right way, and it's always the same way. And that's why David was talking about them being stereotypic movements. And in this case, what we're talking about with a stereotypic movement is we mean a movement that is done the same way each time. And that's a defining feature of tics. It may show up with some other types of behaviors as well, but with tics, this is very much a feature that we're looking for. Now, a quick aside to that is that there are other tic-type disorders that don't seem to follow that same stereotypic pattern of movement. But that's not what we're going to be talking about today. I just wanted you all to know that in case you are experiencing tics or other movements that don't follow that stereotypic pattern, there may be a reason that's happening as well. So going back to what we see with tics, then the individual may not want to perform the movements, but they have to perform the movement anyway. And what happens when they need to perform the movement but aren't performing it is that it tends to feel increasingly uncomfortable. And the type of discomfort, it can be varied. It can seem like a sensory sensation, like almost like something in the body. It may just be an increasing feeling of something is wrong, and they just feel more almost emotionally agitated or uncomfortable. So that's the premonitory urge. And the premonitory urge isn't always going to be felt in the same way. It can manifest in a variety of ways, and that's because the brain is really a very remarkably creative organ that we have. And so it can do a lot of different things to prompt action and to make us engage in action. But the attempt to suppress a tic tends to produce an increasing feeling of discomfort. And then only by performing the action is that feeling then really relieved, or so it would seem. Other things that David had mentioned also is that there has to be persistence of these movements. And in this case, if the movement is persisting for more than 2 months, that's probably worth getting checked out. It doesn't necessarily mean it's Tourette's, but it may be a transient tic disorder, or it may be something else. But it's just at that point, if this is a movement that's persisting for that length of time and it tends to produce that level of discomfort, then it's probably appropriate for you to begin seeking some kind of help for that. And advocating for your needs, because this is something that doesn't seem to make otherwise a lot of sense for you. So let's go ahead and go to the next slide, please. All right, so the process of getting diagnosed, I always recommend that we first get a medical evaluation to rule out other possible causes, right? So as was mentioned earlier, then we want to make sure that the tics are not, there's not another explanation for it, for why it's happening. And that means that you need to get a medical evaluation to make sure that there isn't another cause for it. At that point, then we might spend time assessing for the presence of tics and to see which ones are currently being experienced. When we assess the present tics, we look at the variety of tics. So how many different kinds are there? We look at the frequency, how often are they occurring, and the amount of impact that they're having on the person's life. So tics may range from being kind of a nuisance or inconvenience for the person to something that's really severely affecting their quality of life, either by causing physical harm, emotional harm, or just interfering with activities that the person wishes to engage in, but is not because of the tics. So we need to assess those things. And then we want to assess the family background to see if there is a family history of tics or related concerns. That might mean that there's no clear family history of tics themselves that people are aware of as having been tics, but they may recall, like, oh, well, I had an uncle who tended to do this thing where he was clearing his throat constantly. We didn't really know why, and it just seemed to go on far longer than it would be explained by like allergy season or something like that. But we just overlooked it and moved on. And therefore, nobody pursued it or really recognized it for being what it was. We also would want to typically assess for a family history of related concerns that tend to show up with tics. So we might check in to see if there's a family history of ADHD, acute anxiety or panic, of OCD or obsessive compulsive behaviors that aren't specifically OCD, or body-focused repetitive behaviors like hair pulling or skin picking or things of that nature. So we often want to assess because those characteristics may be present in close family members, and that would further indicate to us, like, well, okay, it might be indeed that we're looking at Tourette's here. And then also we're going to assess for the presence of those co-occurring concerns in the individual who's presenting for evaluation. So the person coming in for assessment for tics, we're also likely going to need to check to see if they are experiencing significant concerns with ADHD, anxiety, mood regulation, and other types of compulsive behaviors. Let's go ahead and go to the next slide, please. So we might look at using some specific evidence-based measures for doing this. So we can do it in a very structured way. So these measures aren't by any means the only ways that we can assess for it. It's just that they're a reliable way that we can assess for these things. And they help the clinician to know, like, oh, these are the things I should be asking about and checking just to make sure I'm covering all my bases. So the YGTSS, or the Yale Global Tics Severity Scale, is one of the most common measures that I and my colleagues use when assessing for tics. And it's a fairly detailed process of assessing for the tics that are present now, tics have been present before, and the first known manifestation of tics, both vocal and motor tics. So it just gives us a way of very systematically going through and assessing that history and then the present level of impact. So how much is it affecting the person's life now? There are other measures that we might use, including the premonitory urge for tic scale, the PUTS, the PTQ, the parent tic questionnaire. So we use all those kinds of measures as a way of checking in for present tics and history of tics. And then we also use measures that can help us assess for related concerns like anxiety, ADHD, OCD. Not all these measures are necessarily required for everyone. So the clinician should be able to say, like, well, these are the ones that I should be checking in on for this individual because of my intake screening or diagnostic history that they've already done. And so they should go through kind of and check in with the individual to see what is present for them, and then use that to guide the selection of what measures will be most useful. We don't want to necessarily assess for everything for every individual. It might be a waste of time, and it can also be kind of boring and a little stressful. Some of these measures are more for children, and some of them are more for adults. Let's go ahead and go to the next slide, please. So, on the more practical side, one of the things that I find helpful for working with adults and children who are dealing with tics is teaching them how to kind of accept and be aware of the waxing and waning that naturally occurs with Tourette's. Tics tend to have times when they get worse and times when they get better, and that change may have nothing to do with what's going on in the person's life. Now, that said, what's going on in their life can also contribute to it. So there's this natural waxing and waning, and then there are external factors that can also affect the severity of tics. Being able to recognize I'm in maybe a waxing period right now where my tics are getting worse, and I need to take care of myself during this time, that can help to make it less stressful. And by making it a little bit less stressful, then it also tends to reduce the severity of the tics, and more importantly, the impact of the tics. So even if my tics are worse right now, if I'm taking care of myself, I'm perhaps not as bothered by it, and it's not affecting my life as much. And that's a good outcome. So we want individuals to learn how to recognize and accept there is this waxing and waning, and I can recognize when that's happening in my life and do what I need to do to take care of myself during that period of time. That way, we're not viewing the change itself as a problem, because then we're just compounding things. So if I am experiencing a worsening and I'm thinking, oh, this is bad, this is really bad, it's a problem, it shouldn't be happening, why is this happening? And then I don't know necessarily, then I get a lot more stressed out, and that has a lot more effect on my quality of life. So yeah, I think it's helpful to recognize it. Let's go ahead to the next slide, please. Now, a common question that I've seen brought up is, what's the relationship between Tourette syndrome and autism spectrum disorder? And at present, we don't know of any clear relationship between them. We do know that individuals with Tourette's seem to have a slightly higher rate of diagnosis of autism spectrum disorder than the general population. It doesn't seem to go the other way around, though. We don't see more Tourette's necessarily in the population with autism. We also don't necessarily know why this is the case. So there's an understanding that perhaps we're more likely to see a social impact for individuals with Tourette's that could also lead then to a clinical diagnosis or identification of autism spectrum disorder without it necessarily being autism spectrum disorder. And we can get very muddied up in the diagnostic clarification, but ultimately, what's more important is that we're able to recognize what the individual's experience is and what kinds of support services they will benefit from. So if they're experiencing social difficulties and they have Tourette's, then we do need to address those social difficulties, whatever the cause. So the simple answer is that there's not really a clear answer right now for autism and Tourette's, but we do tend to see a more frequent co-occurrence between those two. Both of them are considered forms of neurodivergence, meaning they are a difference in neurological development from what we typically see in the larger population. The same could be said for ADHD as well, that there's a difference there when contrasted with the larger population. It's not necessarily a deficit or a disorder, but it is a difference. And the society we live in is built around the expectations of typical sequence of neurological development. So it makes demands that maybe the individual is not well suited to meet. All right, so let's go ahead and go to the next slide, please. And we're already at 7:46. I'm going to see what I can do to go through this. David's already discussed some of these co-occurring challenges, which I don't really have a lot more to add necessarily. I think understanding that there are a lot of co-occurring challenges for individuals with Tourette's is helpful for those who are experiencing those challenges, so that they know, okay, it's not necessarily more than just, it's not an additional problem I need to be worried about. It is something that's to be expected. Let's go ahead and go over to the next slide, because I've got to get into the emotional regulation component, which, this is timely, right? Because there's a new movie from Inside Out, Inside Out 2, and so anger's back. But it's also just a handy graphic. So individuals with Tourette's are more likely to be identified with oppositional defiant disorder, intermittent explosive disorder, disruptive mood dysregulation disorder, which is kind of like, you could say, chronic irritability and crankiness, which is a childhood disorder, or at least that's the way that we would identify it. So there is a tendency for the Tourettic brain to push back more and to experience emotions more potently, so stronger emotions. And that can lead to a lot of challenges, especially for children, because it tends to produce a lot of behavioral challenges that the adults don't know how to cope with or respond to, which if the adults don't know how to respond to, then that tends to further aggravate the experience that the children are having and the complications that they're having in the classroom and at home, and it kind of becomes a cycle. We like to disrupt that cycle if we can. But that means that we need to have some understanding and awareness of what's going on, that the Tourettic brain does tend to experience emotions more acutely and struggles more with sort of metaphorically putting on the brakes or slowing down the response. So the response is likely to manifest before the individual even has a chance to say, like, what do I want to do? They're already doing. So it's not necessarily well planned and thought out, right? These are intense responses and often then become maladaptive responses because they don't result in a good outcome. Let's go ahead to the next slide. I'm going to come back to that emotional component as well when I get over to parenting and spousal stuff. So the quick last bit to address with why is Tourette's often missed in childhood? David's already covered a lot of this actually very well with one of those slides toward the end of his presentation. One of the most common problems we run into is that Tourette's is often missed in girls. And this is because girls are less likely to exhibit what we call externalizing behaviors, which are outwardly directed behaviors. Externalizing behaviors make people pay attention, and they're really good at drawing parent and teacher attention so that that child is noticed and people are like, oh, we need to do something about this. Unfortunately for girls, they tend to exhibit less of that in our culture, which means that they tend to be more easily overlooked. And as a result, they may not get a diagnosis of Tourette's. It may not be noticed until much later in their lives. And they receive no support, no education, and just a lot of stress and correction or recrimination for their behaviors that they can't actually help. So missing Tourette's in childhood is unfortunate because it does accumulate a lot of stressful experience for the individual. And we know that this is more often missed in girls, and this is something that we need to work on. I think the first step for that, though, is increasing awareness. Let's go to the next slide, please. Family planning. Now, that was a tricky graphic to find because most of the things I found had clear ideas of what was meant by family planning, which were not what I was looking for. So, family planning. Tourette's does appear to be heritable, as David has already discussed. It is very common for children of a parent with Tourette's to develop one of the common co-occurring challenges. Even if that child doesn't develop Tourette's, they're more likely to exhibit ADHD, OCD, anxiety, and ODD, which is oppositional defiant disorder. So they're more likely to exhibit these things because they are still sharing a lot of the neurological characteristics of their parents. So they may not have tics, but they may have other things. Or they may have very subtle tics as well, which, again, those can be overlooked. And the individual is still experiencing a lot of the side effects of Tourette's, or not side effects, I guess, co-occurring challenges. Similarly, then also siblings of a child with Tourette's are more likely to exhibit these co-occurring challenges, even if they don't exhibit tics themselves. So that doesn't mean that parents should, or people who are thinking about being parents, should decide not to have children just because of Tourette's. Their child may be more likely to exhibit these things, but it's not all downsides. There are benefits, actually, it seems, to this sort of neurological organization and the set of behaviors that come with it. So they may appear to be more anxious, which can be stressful, but that also means that they are, in the extreme, less likely to be surprised and eaten while walking in the woods. And more pragmatically, they are more likely to identify possible problems before they occur and address them. Individuals with Tourette's seem to be very proactive problem solvers. That's not a bad thing, except that sometimes we're solving problems that don't need to be solved. And that can be stressful. Let's go on to the next slide, and I'll continue talking about this. So, yes, responding to some of these challenges that come up then. So the parent of a child with Tourette's is going to experience some of the intense emotionality, right? So children with Tourette's tend to experience more intense emotions, and that can result in some pretty challenging behaviors. The brain of a parent dealing with intense behaviors is likely to feel like it needs to solve or stop that problem. And that can be rather challenging because some of those behaviors we're not going to successfully stop. Sometimes a child is having a very intense tantrum, and we can't stop the tantrum. Instead, we have to learn how to kind of let it ride it out, and it will stop eventually. But parents who have Tourette's themselves are also more likely to notice tic-like behaviors in their children, whether they are tics or not. So that can cause a lot of distress for the parent because they may begin thinking like, oh, my child is showing tics, which they may even just be transient tics, but they're likely to begin to respond quickly to them. Responding quickly to tics that children exhibit tends to reinforce for the brain that the tic is a problem, which actually can increase the likelihood of the tics occurring in the future. So we don't want to be responding a lot to the tics in a way that conveys that the tic is a problem or something that needs to be suppressed or stopped. But that's not easy to do for the parent who has Tourette's because, again, their brain is more likely to quickly identify and feel like it needs to fix it. And they themselves also have good insight into tics because they've experienced those tics themselves. And parents with Tourette's tend to be anxious parents. So they are, again, very keen to solve problems, which means recognizing a problem or noticing them even if they aren't problems. So what we want to do then as parents is learn to practice our own self-care and model that for our children so that they can use that themselves. So they can say like, oh, I need to take care of myself too. So I can recognize I'm getting really stressed and take myself out of the situation or communicate to my child that I need to take a moment to calm myself down. That helps the child learn how to do that for themselves. And that's a really good quality for them to develop. Even if they didn't have Tourette's, it's still good quality for them to develop. So responding to parenting challenges when you have Tourette's partly involves awareness of those challenges as well as then engaging in appropriate self-care in response to the challenges and modeling that for our children. Let's go on to the next slide, please. Um, and yeah, like related to that, then I would say that I really want to convey this message that individuals with Tourette's are as capable as anybody else, and in some ways, very capable or more capable in some skills. So there's as much variation, though, in the Tourette population as there is in the rest of the population in terms of cognitive abilities, academic skill, hand-eye coordination, anything. Any kind of quality that we see variation on in the rest of the population, we do also see that in individuals with Tourette's. And so children with Tourette's can grow up to be just as capable in participating in society and achievement as anybody else can. So it's not condemning children to hardship if you yourself have Tourette's. You can have children and you can teach them skills that they can use to promote their own success. And they may actually benefit even more from that, from learning how to manage their tics if they have them, in a way that they can apply to other challenges that may arise in life. Let's go on to the next slide, please. I think I'm nearly done. Oh, yes, the romantic challenges. Okay, which for that, I just have a clip art of a heart. So the same challenges that show up for an individual with Tourette's and other aspects of their life, rigidity, stress response, managing and coping with frustration, intense emotions, executive dysfunction, and impulsivity, those things tend to affect romantic relationships too. So learning how to be aware of it is the first thing what we use in order to manage it. Well, I can't manage something if I can't tell that it's there. So I want to learn how to recognize when these things are showing up in my life. And then how do I communicate that with my partner? How do I say, like, well, sometimes I do need to take a moment for myself because I sometimes get really overwhelmed with frustration, or I notice that my response was just, it kind of got out of proportion. It was way more intense than I even wanted it to be, and communicating that. And if we can communicate that, then we can actually work collaboratively to solve it. And that's a good thing for a relationship. But if I feel like it's a problem and therefore try to hide it or become frustrated with myself when I do it, I might end up shutting down. And if I shut down, that means I'm not communicating. And that tends to actually interfere with a collaborative relationship, such that we might want to develop in a romantic relationship. So we need to learn how to recognize when these things are happening, and then a way that we want to respond in that moment, and then practice it. Because just because I know how I want to respond doesn't mean I'll be able to do that. So it takes practice. All right. Is there another slide, or is that it? Oh, there is. Well, we're at about 8 o'clock, so I want to wrap up. There are non-pharmacological approaches to treatment for Tourette's, which is a good thing, especially for adults who are new to receiving a diagnosis. I think it's very important to know that we have effective behavioral treatments. CBIT, or comprehensive behavioral intervention for tics, is highly effective for individuals with Tourette's. It's very good at managing tics. The cognitive psychophysiological model, or COPS model, is another approach that has proven effective, statistically effective, with helping individuals with Tourette's. And that one works on both tics as well as managing some of the emotionality that we experience with Tourette's. So both of these are good approaches. They were originally developed to be applied to adults, so we don't need an adaptation for those. They have been adapted to be applied to children, and they're proving effective there as well. Let's go ahead and check the next slide. Is that the last one? No, but we'll go ahead and skip that for the moment. Okay, so regarding the last slide, which we don't need to skip back to, the main thing I would want to say there is just that it can be hard to find professionals who are knowledgeable and skilled in working with Tourette's, but you don't have to find somebody who's capable and especially knowledgeable of treating Tourette's to work with the co-occurring challenges like ADHD or executive dysfunction, anxiety, OCD, emotionality. Those things can be helped by other professionals, even if they don't have expertise in Tourette's, and they can improve the quality of life for an individual with Tourette's. So even if you can't find an expert in Tourette's, you can still get benefit. All right. I'm done.
Well, thank you so much. Thank you so much, Charles. I want to just remind everybody, as promised, this is the QR code for the survey for today's programming. Please take some time to scan that QR code and submit your feedback. We are, as promised, we are a little over, but I think that also shows the importance of this topic. There's a lot to say, right? So we're still going to have a Q&A, everybody. I want to make sure that we honor that. And I want to give a little time. I do see that my amazing panelists here have been answering some questions on the side, but I especially want to give some time to have Darren come in and answer some questions with the lived experience perspective that he has being diagnosed in adulthood. So if it is okay with everybody, Darren, I am going to start with you. And I think one of the questions that we had actually in registration may be a good place to start. So specifically from your experience, how would you, the person who asked said, how would you explain to parents that you have Tourette syndrome when finding out in adulthood?
Thank you, Alexandra. First of all, I want to go on record as saying that I get to go first next time. I also want to go on record as saying that I agree with everything David and Charles said. That was a wonderful presentation. I wasn't watching the clock as much as I was watching and listening to them. The answer to the question is, that's not as simple as it sounds. I am a huge fan of the truth, right? Whenever I hear somebody say, well, they're too young for me to tell them that they have Tourette's, I'm like, no, there's a 3-year-old, 5-year-old, 7-year-old version of you have Tourette's. There's no such thing as it's too early to start explaining and getting them to the normal of what their Tourette's is like. I also think in the other direction that there's no such thing as too old to find out about your Tourette's or to deal with your Tourette's. In one of my support groups that I led, specifically focused on Tourette syndrome, we had a 78-year-old man come in and sit down at the table. And we started the group and everything. And finally, somebody said, I got a question. You just said you were diagnosed a month ago. You're 78. And he's like, yeah, I'm not dead. He was there to fix and to do what he could to learn about it so that he could live a better life at the age of 78, which I thought was amazing. He's one of my heroes. The explanation of Tourette's is, if you're talking about an adult explaining to their parents that they didn't get diagnosed until they were an adult, that's a tough one. I would start with just being very factual and very basic. It is tough. And sorry guys, this is tougher for the fathers than the mothers, but it's tough for the parents to find out that they missed something, or if they felt like something was going on, then you are looking at parents who are feeling like they failed their child, possibly. And I have to say that is complete garbage. That's not true at all. The parents who are upset that they didn't figure out that it was Tourette's, first of all, that's not really their job. It's not fair to say that they have to have been able to have done that. But secondly, if they're upset that they feel like they failed, then they're probably doing the best that they can. They care about their children. They're trying to give them a good life. And what I would also say is that the guilt is irrelevant and useless. It's not only a waste of energy, it's just not constructive at all. Because in my particular case, I was not diagnosed with Tourette syndrome until after I'd flunked out of college a couple of times. Now, obviously, the Tourette's wasn't the reason for the problem in college. It was the ADHD and the OCD and the learning disabilities and et cetera, et cetera. But my mother has been a special educator as long as I have been conscious. So for someone to come to me and say, well, I'm his parent, I was supposed to know this, I'm like, no. If professionals in the field can miss this, then I don't think anybody who's not directly related to this field has any reasonable case for feeling guilty or feeling to blame for that. I hope that helped address the question, even if it didn't actually directly answer it.
Amazing. Well, I have another question for you, Darren. We have a registrant who asks, as someone who's diagnosed in adulthood, how do I meet other adults with TS in my area? What from your personal experience would be helpful to the answer?
That's a very good question. I would absolutely start with the Tourette Association and see if they can get you in touch with someone who leads the group in the local area. Now, of course, we're talking about, you know, the entire United States. There are some areas of the US that don't yet have an organized function in their you know, in their state or in their area, but that's a good place to start. Another place that I would look is and I'm not kidding at all, I would look for things like Facebook groups and meetup groups, meetup.com, because there are other adults with Tourette's trying to meet other adults with Tourette's online. Now, there's a caveat to the Facebook thing, which is that unfortunately Facebook has a lot of bad information in it. But if your goal is to find other adults with Tourette's so that you can be part of this community, then I think that that's a reasonable, those are reasonable tools to do that. So.
Amazing. The next question we have, Darren, again, is how can I better advocate for myself when I feel like my experience with TS is less valid since I didn't grow up knowing I had TS?
Wow, that's a fabulous question, but I just want to be clear that first of all, the Tourette's itself doesn't care whether you're aware of it or not. The damage that Tourette's does to our self-esteem doesn't require you to have a diagnosis and self-awareness of the Tourette's. If you grew up as a child and you were bullied, or you felt like something was wrong, or you weren't as name something as one of your siblings who didn't have Tourette's, I think that all of that stuff that happens with Tourette's is completely regardless of when we find out about it and how we get diagnosed and how accurately we get diagnosed. The flip side to that is that there is no such thing as, well, I got diagnosed when I was 7, therefore my Tourette's is better than yours, or even that my experience was better than yours. We are still, like yesterday, dealing with adults with Tourette's who are struggling to get their civil rights fulfilled, to getting their employers to follow the federal guidelines for a disability access. So never in those conversations do I say to somebody, yes, but when were you diagnosed? Doesn't matter. You qualify or you don't qualify, you have it or you don't have it. The struggle exists whether you know its proper name or not. So I hope that helps.
Amazing. Well, I am mindful of everybody's time. I know we are 10 minutes over. And like I said, I really do feel like this is because there is a lot of great information to be shared on this topic. Again, please fill out the survey, provide us some feedback, and give us some insight as to if you'd like to have perhaps another presentation on this topic. As like I said, we went over, so there's a lot to be said. I want to thank our panelists for being here today. They're all so appreciated and so amazing. And thank you all for coming today as well. We hope to see you again very, very soon. Thank you.